Welcome to the Agora Medical Education Centre. This surgical video has been produced to help facilitate learning for doctors of all levels in their knowledge and skill in the surgical management of uterine septum. This training video will cover the background of uterine septum, including the embryological development and the clinical implications, the diagnosis, including imaging modalities and timing, preoperative, including equipment required and surgical setup. Then we will discuss and show the step-by-step hysteroscopic transcervical resection technique and finish by outlining our routine post-operative care and outcomes. The female reproductive tract develops from a pair of Müllerian ducts that form the following structures: the fallopian tubes, the uterus, the cervix, and the upper two-thirds of the vagina. The ovaries and lower third of the vagina have different embryological origin. Normal development of the Müllerian ducts depends on the completion of three phases: organogenesis, fusion, and septal reabsorption. Errors in each of these phases can lead to different uterine anomalies. The biological basis for the impaired reproductive outcomes in women with a septate uterus has not yet been clarified. Septum tissue is thought to be more fibrous with fewer blood vessels. This may affect implantation, fetal and placental development, and can lead to infertility, miscarriage, and premature birth. The definition and management of a septate uterus remains a controversial topic. Recent data from an international multi-centered cohort study are inconclusive, observing the success of this procedure regarding fertility. Preoperative transvaginal ultrasound scan, pelvic MRI scan, or suspicion at laparoscopy surgery may lead to the suspected diagnosis of a septate uterus. However, it is only at the time of a diagnostic hysteroscopy that the diagnosis and extent of a septum can be confirmed. The procedure is carried out under general anesthesia with the patient in a lithotomy position. An initial diagnostic saline hysteroscopy in this case was performed prior to confirm the suspected diagnosis. The technique in this video utilizes a monopolar resectoscope, hence glycine is used as the distension medium. A speculum and vacellum tenaculum are placed to facilitate access to the cervix. We used a 22 French resectoscope, so the cervix was dilated to a Hagar of 8 mm. The aim is to dilate the cervix enough to allow insertion of the resectoscope while keeping a tight seal around to avoid any fluid leakage. As demonstrated, the monopolar diathermy tip is placed at 90 degrees to the septum. The resection is performed gently and gradually from the midpoint of the septum. It is important to ensure the tip of the diathermy is always in view and in control. One of the risks of this procedure is a uterine perforation and intra-abdominal visceral damage. To avoid this complication, please note the appearance and texture of how the septal tissue and the myometral tissue differs. Additionally, the anatomical landmarks of the ostia of the fallopian tubes helps orientation. Throughout the procedure, the septal tissue is divided with the cut diathermy function, and hemostasis is ensured with the coagulation diathermy function. The settings used in this procedure were 60 coagulation and 40 cut. This patient made a rapid recovery with no surgical complications. We advised 2 months prior to conception. Many thanks for listening and watching this surgical educational video produced by Agora Medical Education Centre.